Testosterone is the principal hormone in assessing male fertility index, and its secretion and functions can be affected by metabolic abnormalities caused by diseases and infections such as HIV/AIDS. So infection with HIV is associated with endocrine abnormalities, including hypogonadism, a condition in which the male testes or the female ovaries produce little or no sex hormones, which can cause an endocrine disruption and metabolic abnormality when left untreated and poorly managed. So with the use of the antiretroviral therapy in clinical management of HIV-infected patients, there's a decrease in prevalence of hypogonadism. However, the effect of chronic inflammation on endocrine and metabolic functions remains a matter of concern, mostly as a result of drug toxicity associated with the antiretroviral therapy. So for this research, weighed number of problem statements. The first was for the proper function of the male body, sufficient level of testosterone hormones are required. So prior to introduction of the highly active antiretroviral therapy, hypogonadism occurred in approximately 50% of AIDS patients. Though these are diminished, but still it remains higher among the HIV-positive males. So symptoms of hypogonadism include low sex drive, alopecia, and erectile dysfunctions, among others. And most studies on HIV and hypogonadism have been done on male above the age of 45 years. So our major concern for this was you get the adolescents and the young adults, they're still interested in having offspring in future. But above the age of 45, they're done with that phase of life. There's also limited information on the influence of the combined antiretroviral therapy on testosterone production among adolescents and young adult males who are HIV positive. So the knowledge on the effects of the ART on testosterone production in adolescents and young adult male is important in guiding treatment of these patients and the use of testosterone therapy in HIV patients. General objective was to determine the effect of the ART on reproductive hormone levels among the human immunodeficiency virus patients, male adolescents, and young adults on ART. So the first specific objective was to find if there's a difference between the blood serum levels of testosterone, progesterone, luteinizing hormone between the HIV positive and the HIV negative adolescents and young adolescents male receiving ART over different exposure period. The second objective was to determine the effect of different antiretroviral therapy combinations on the blood serum level of testosterone, progesterone, and the luteinizing hormone among HIV-positive adolescents and young adult male. And the third objective was to find a correlation between CD4 count, plasma HIV viral load levels, and the serum level of testosterone, progesterone, and luteinizing hormone among the HIV-positive adolescents, young adult males receiving ART therapy. So for our justification, we assume testosterone hormone is among the key androgens in male body, and it plays a vital role from the 8th week of development to adulthood. And also progesterone is also an important hormone in male, though it's mostly ignored, but it influences spermiogenesis, sperm capacitation or chromosomal reaction, and testosterone biosynthesis in the Leydig cells. And then also its metabolic impairment as a result of disease and infection can lead to health problems that directly affect male fertility. So metabolic abnormalities due to drug toxicity have been detected from ART treatment, raising the need for research related to the management of HIV infection. There's limited knowledge on the effects of long-term ARVs use on hormones, secretion, and function, especially among persons below the age of 45. It is for this reason that this study was conducted to ascertain the influence of the ART on the level of the 3 hormones. So our study design, we adopted a cross-sectional case study control a cross-sectional case control study design using HIV positive and the HIV negative adolescents and young adult male participants. Our study site was at the Comprehensive Care Clinic and the blood transfusion unit of the Kenyatta National Hospital. So our positive came from the comprehensive care and the negative cohort from the blood transfusion unit. The study population included adolescents and young adult male participants whose age ranged between the age of 15 to 25 years. The cases were much in the ratio of 1:1. And the inclusion criteria for one to participate, they had to be between the age of 15 to 25 years. They had to be HIV positive, receiving their antiretroviral therapy at the Kenyatta National Hospital for cases, and HIV males for control groups. Patients who gave signed informed consent for those above 18 years and assent from parents, consent of guardian for patients below 18 years, and participants had to accept for a physical examination to assess their pubertal status prior to enrollment in the study. So exclusion criteria, we excluded patients who did not attain puberty and the HIV positive patients who are passing by the KNH just for a one-time drug fill-up but are registered as patients at a different comprehensive care clinic. So the laboratory procedures involved measurement of the serum testosterone, progesterone luteinizing hormone, a CD4 count, and doing the HIV viral load only among the positive cases. The data analysis was performed using our software packages for social sciences, SPSS, version 25. The study was approved by the Kenyatta National Hospital, University of Nairobi Ethical Review Committee. It was given a permit number 857/11/2023, and the signed consent or assent was required from each participant prior to participating in the study. So the expected outcome was that the results of this study was expected to add our knowledge in the effects of ARVs on male reproductive hormones among adolescents and young adults. And also our thesis said to be submitted to the University of Nairobi for the award of Master of Science in Reproductive Biology. And the results of this study will be shared with the site of the study scientists in peer-reviewed journals and scientific conferences. So these are the results which we found. 70 participants were enrolled, 34 HIV negative, and 36 were HIV positive, and had and attained puberty. So the mean age was 21 years, and our distribution for the participant was that 12 participants were on medication for more than 16 years, 10 had been on medication between 11 to 15 years, 11 participants were on medication between a period of 6 to 10 years, and 3 were on medication for a period of between 1 to 5 years. Antiretroviral medication, a majority who are 30 participants were on the TDF, 3TC, and DTG combination, and only 1 participant was on TDF, 3TC, DTG, HIV, and R combination. So these are the results. So the reproductive hormone levels between HIV positive and negative adolescents and young adult male. So we found out that the serum hormonal level of testosterone, progesterone, luteinizing hormone were within the normal biological reference ranges for both HIV negative and HIV positive ions. All hormones were slightly higher among HIV positive participants in comparison to HIV negative participants, though this did not change after adjusting the duration of HIV diagnosis. And there were also no statistically difference between the mean hormonal levels of progesterone and testosterone among the two groups. However, there was a statistically significant difference in the mean level of serum luteinizing hormone between the two study groups with the HIV participant, recording higher levels of luteinizing hormone compared to the HIV negative participants. But the luteinizing hormone levels are within the normal biological reference ranges, but slightly elevated. The second objective was to determine the ART combination on the blood serum levels of testosterone, progesterone, luteinizing hormone among the HIV positive adolescents and young adult males. So there are no significant difference between the serum hormonal levels and the medication combination. The third objective was a correlation between plasma HIV viral load levels and serum levels of testosterone, progesterone, and luteinizing hormone among HIV-positive IM receiving ART therapy. Our findings showed that there was a statistical significant positive association identified between viral load levels of testosterone and progesterone, suggesting viral load may influence these hormones under certain conditions. So an association the association was not consistent across all the measurements, indicating that additional factors may mediate or modulate this relationship. So overall, no association was observed between viral load and LH levels. So for the final discussion, we realized that the level of testosterone and progesterone hormone remain within normal ranges across both groups. We had elevated levels of luteinizing hormone, which was observed among the HIV-positive cohort. That reflect an early subclinical disruption of the hypothalamic pituitary gonad HPG axis, despite preserved testosterone levels. Our third observation was that there was an association between viral load and select hormone levels, testosterone and progesterone, although this was not consistent across all the time point or for the luteinizing hormone. So the recommendation from the study was that in future, maybe there should be an integration of routine hormonal screening into HIV care, not only for the adolescents and young adult male, but I think across the adolescents and the young teenagers. And also, maybe if in future someone can conduct a longitudinal research on the antiretroviral therapy and the hypothalamic pituitary gonad axis functions, and also expand the hormonal and fertility assessment in HIV-positive male adolescents. We'd like to acknowledge and thank the University of Nairobi, the Department of Veterinary Anatomy and Veterinary Physiology, and also the University of Nairobi Department of Pediatrics and Child Health for their support and contribution, and thank the Kenyatta National Hospital for the support, and UCAS for the platform, and also thank the co-PIs, Dr. Albert Nyongesa, Dr. Rodio Jo, Dr. Priska Molo, and Professor Dalton Amalwa, and above all also thank the participants for the UCAS event. Thank you.